Good morning and welcome to the 13th meeting in 2014 of the Health and Sport Committee. As usual at this point, I ask everyone in the room to switch off their mobile phones, Blackberries, etc., as sometimes they can interfere with the sound system and disrupt the committee. I should also point out that some members and officials are using tablet devices, and this is instead of their hard copies of the papers. We have apologies from Nanette Millen and Richard Lyle. Once again, Jackson Carlisle joins us as committee substitute for the Conservative Party. Welcome again, Jackson. And of course, Dennis Robertson from the SNP. Welcome to you both. The first item on the agenda this morning is subordinate legislation, and we have 4 negative SSIs to consider. The first instrument is Health Professionals Council Registration and Fees Amendment, Rules 2013 Order of Council 2014, SI 2014/532. There has been no motion to annul. The Delegated Powers and Law Reform Committee has drawn the attention of the Parliament to the incident, and the details, of course, were in your papers. Do I have any comments from the members? I have no comments then, and move and to ask the committee if we are agreed to make no recommendations. Are we all agreed? Thank you. The second instrument is National Health Service Charges to Overseas Visitors, Scotland Amendment Regulations 2014, SSI 2014/70. There has been no motion to annul. The Delegated Powers and Law Reform Committee has drawn the attention of the Parliament to the instrument, and the details, of course, were in our papers. Is there any comments from members? No comments. Is the committee therefore agreed to make no recommendations? Thank you. The third instrument is National Health Service Physiotherapists, Podiatrists or Chiropodists, Independent Prescribers, Miscellaneous Amendments, Scotland Regulations 2014, SSI 2014/73. There has been no motion to annul. The Delegated Powers and Law Reform Committee has made no comment on the instrument. Is there any comment from members? There's no comment. Is the committee therefore agreed to make no recommendations? Agreed. Thank you very much. The fourth instrument is Glasgow Commonwealth Games Act 2008, Duration of Urgent Traffic Regulation Measures Order 2014, SSI 2014/92. There has been no motion to annul. The Delegated Powers and Law Reform Committee has made no comment on the instrument. Are there any comments from members? There is no comment from members. Therefore, is the committee agreed to make no recommendations? Thank you. We now move to agenda item number 2. Which is the Scottish Government Action Plan for Pharmaceutical Care. And can I welcome our first panel this morning, Professor Bill Scott, Chief Pharmaceutical Officer, Deputy Director, Finance and E-Health Pharmaceuticals Directorate, and Alpana Mayer, Deputy Chief Pharmaceutical Officer, Finance, E-Health and Pharmaceuticals Directorate, Scottish Government. Can I invite from Professor Scott an opening remarks, please?
Yes, thank you very much, Convener, and thank you, Committee, for inviting us to come and talk about our action plan and vision for pharmaceutical care. Prescription for Excellence builds on the direction of travel of our progressive and developing policy landscape for high quality, sustainable health and social care, and the comprehensive year-long study and review of NHS pharmaceutical care undertaken by Dr. Hamish Wilson and Professor Nick Barber, which concluded in the autumn of 2012. The study undertaken by Wilson and Barber was underpinned by a wide-ranging and lengthy engagement and evidence-gathering exercise. Importantly, Prescription for Excellence is predicated on the Scottish Government's 2020 vision, route map and quality strategy ambitions. It plays to the strengths of pharmacists as experts in the therapeutic use of medicines and their potential contribution and integration into health and social care teams. It is important to emphasise to the committee that pharmaceutical care and our vision and action plan transcends that which we traditionally associate with the services available from our local high street pharmacies and the common perception of what a pharmacist is and does. It goes beyond the practice of the individual pharmacist. It involves new innovative models of care and pharmacy practice that will be crucial to how we address the very real healthcare challenges we face as we go further forward into the 21st century. It involves a different approach to practice, which requires pharmacists to work in partnership with patients and other health and social care professionals. The Cabinet Secretary has emphasised the continuing and important role pharmacists located in our communities and high streets across Scotland, and that is quite so. They are the first port of call in our healthcare system. What will be important is their future relationship with other local health and social care providers. This is crucial for the future service planning, particularly in remote and rural areas and deprived communities in Scotland. Over the years, we should be very proud that the NHS pharmaceutical care in Scotland has established a well-earned UK and international reputation for innovative models of care. Prescription for Excellence is already following in this vein, with others in the UK and abroad following developments closely. Prescription for Excellence keeps Scotland at the forefront of innovation and high-quality pharmaceutical care and will make a significant contribution to our shared goal of world-leading healthcare. But most importantly, Convener, it puts the patient at the centre of our health systems. Thank you.
Thank you, Professor Scott. Aileen MacLeod, please.
Thank you very much, Convener, and thank you to Professor Bill Scott and Talpana Mayer for coming along this morning. The first question I wanted to ask was just in terms of, a number of those who have submitted written evidence to the committee have discussed the policy context to the strategy and action plan, including reference to the previous pharmaceutical strategy from 2002, which was the right medicine. And of course, we've had the Wilson-Barber review that was launched last August. Can I ask what benefits has the previous strategy brought to the delivery of pharmaceutical care services and how the new strategy builds upon that, and particularly in light of the 2020 route map?
Yes. Before we had the right medicine, pharmacies were mainly concentrating on the dispensing process. We brought in with the right medicine to the pharmacy contract the chronic medication service, our minor ailment service and public health services. They have started to build into services which patients register for, and they are starting to demonstrate a great deal of success, particularly minor ailments where patients can go in and register for this service. The service was brought in under the auspices of social justice, and it's there to help people who either are of low income or have young families, and for people over 65. The chronic medication service, which I have to say patients don't particularly like the word chronic, and we think we'll have to just change the wording a bit. But that is there to help pharmacists identify patients who need more help in understanding their medicines, taking their medicines, and we have added in other areas such as identifying high-risk medicines. So it has started the route of pharmaceutical care on the march.
Thank you very much. And just as a follow-up, convener, I mean, obviously, in terms of the action plan and the review itself, I mean, there are a lot of recommendations within that. I just wanted to ask, how is that work being taken forward with the stakeholders? I mean, how is the government engaging with the stakeholders and taking forward the work of the action plan?
Certainly. The first thing was that Wilson and Barber had a number of meetings with all of the stakeholders, and that's when they made the recommendations. We then looked at the recommendations, but also at that time, the health and social care work was going on in the department, so we wanted to blend them together. And where we are now is to start taking forward with the stakeholders the work which will help deliver the actions.
And in terms of the steering board, perhaps you could talk us through that, in terms of who sits in the steering board, how often that steering board will meet in taking forward the work programme.
Yes, I'll do that. The steering board is a high-level board, and the people who are on it are either involved in the NHS or in the Scottish Government itself in delivering other parts of the health and social care strategy. And I think I'll ask Alpna if you could give the...
Okay, thank you. We have on the steering board most of the directors within Health and Social Care Management team, and that's really to ensure that Prescription for Excellence, the work that's been delivered in that, like you rightly pointed out, it cuts across the 2020 route map, delivers in areas of primary care, health and social care integration and scheduled social care. So the reason for doing that is obviously their involvement in ensuring that work packages within Prescription for Excellence get incorporated into their work plans. And indeed, at that first steering board, there's a real commitment from the group members to look at their work plans to how we integrate pharmacy into other areas of healthcare delivery to make sure that we have a patient-centred strategy. In addition to the directorates across health and social care, we also have a medical director who represents the group of medical directors and a director of pharmacy, together with the Royal Pharmaceutical Society and the Royal College of GPs, who are there actually to represent all the Royal Colleges. And also have the chief social worker that's part of that group as well, to make sure that we have the integration across health and social care as well. So that's the steering board, and then alongside that will sit a reference group which will have a wider stakeholder membership in that group.
And also different work streams as well. I mean, how often will the steering board be meeting?
It's anticipated that the steering board will meet about 3 or 4 times a year. We had our last steering board meeting, our first steering board meeting last week, but we all agreed that actually in between the steering board meetings there'll be work that needs to take place from all the steering board membership, and that's been agreed. Our terms of references were agreed at that first meeting. So although we'll meet physically, there'll be work programmes that the steering board will take forward and deliver on. What's important to say is that there will be a core programme management team that will implement the work packages that are designed to deliver the action points that are addressed in Prescription for Excellence, and that will draw on members that are relevant, including the stakeholders, to be part of those work streams, and the steering board has been asked to consider that piece of work and consider membership of that piece of work.
Okay, thank you.
Okay. Richard Simpson.
Can I start by saying that I'm hugely supportive of the direction of travel that we've been taking in Scotland, which is quite different to that in England. And I think getting pharmacists and indeed optometrists and others as full partners within the health service is actually critical. But there are clearly problems which are related to the fact that they are not direct employees of the health service. And indeed, unlike GPs, where at least we have, they may be independent contractors, but we have a pretty firm contract with them. The pharmacy contract, which now proposes to have a named pharmacist for every patient and have every pharmacist as a prescriber, I think is highly aspirational and challenging, which I welcome. But I just wonder, you know, if you could give us a little more detail on how you're going to get this in place, given that we do have the situation of that many of the community pharmacists are not individual ownership, but are actually big multiples. They are private firms like Boots and Lloyd's. They have an ethos which overlaps ours, but isn't exactly the same as ours. The pharmacists are going to move around. You know, I can see lots of problems because of that. So I wonder if you could elaborate a little bit on how you see that developing.
Certainly. As we all know, NHS Scotland is a free, truly public service built on cooperation and collaboration. The retail sector in which community pharmacy is classed is about competition and footfall. For the purposes of providing patient-centred clinical care, we must change behaviours. You can still be competitive on your sales, but the need for cooperation and collaboration to deliver NHS care will be what will be expected of you. As young trainees go through the schools of pharmacy, we are looking at combined training in some cases with medical colleagues at undergraduate. And we want to get a culture of working together for the patient. And we, in discussing with the large companies, part of that will be when you're providing a service for NHS Scotland, then you will provide it in a way which is on collaboration and cooperation.
Well, I very much welcome that, and I think that's the ethos that all four parties are supporting in Scotland now, and I think it's you know, it's good that we've got an agreement on the general direction of progress. But I still have some concerns, particularly on some practical issues. We still have paper prescriptions handed to the patient. The pharmacists don't have access to the emergency care record, as far as I know, just yet. And as part of that, I think I would ask if you have a separate work stream looking at the IM&T side of it, because ultimately, you know, we should take this out of being paper, but I think that what we're going to need far greater. We talk about patient-centered all the time, but to be honest, it's still actually tends to be producer-oriented, and ensuring that the patient actually has control over their own data by actually saying yes to the pharmacist, you can access this, and I will put a code in, which just like a bank code, that, you know, you put the last 4 digits of your CHI number in, would allow the pharmacist to have access to the emergency care record, but keep it under the control of the patient. Sorry, I'm suggesting solutions, Chair, and I shouldn't. But you know, the principle is there. If we don't really have genuine patient control, I have worries in the future about confidentiality and privacy and all these issues.
I totally agree with you. We don't want to see the patient as a victim. The patient has to be a partner in this. And we have put a lot of effort into electronic prescribing. We now have in Scotland every general practitioner and every community pharmacy linked electronically. And part of the chronic medication service is that you will be able to get your prescription transmitted over to the pharmacy. Now, we met our target to get everyone interconnected by December last year. Our target this year is to ensure that GPs become familiar with the repeat prescribing system. And we've set a target that we should have that well underway by December 2014. And in fact, there are pharmacies now receiving those electronic prescriptions. We will have to get rid of the paper, and we'll have to find ways of signing for the prescription. But that, I don't think, is going to be a problem in the end. And as you rightly say, this information has got to be under the patient's control.
I might want to come back later, Chair, but
I might consider letting you back later. Bob Doris has got a supplementary question on the name pharmacy.
Yeah, fairly brief one. I'm like Richard Simpson. I'm drawn to the idea of a named pharmacist, and also see obviously the pharmacy listed with NHS boards as well, and that information held and used to really advance community pharmacy. I noticed that Community Pharmacy Scotland, who will be given evidence later, seem to have some kind of nervousness around that, but they can kind of put their own information on record in relation to that. The only thing I would ask for clarity is that as long as this is inclusive, so as long as any individual patient can still walk into any community pharmacy on the high street and get a service if they wish. So if you could confirm if that will still be the case, it will be inclusive. If that reassurance can be given, then I think it's quite good that the individual pharmacist-patient relationship is built up and strengthened. So with that one caveat, I would welcome this idea, but can you give that reassurance?
Yes. The reason that we've got the name pharmacist down there was when Wilson and Barber were talking to the Patient Alliance and other patient groups, it was patients that wanted the continuity. And in fact, with CMS at present, you register and you register with a named pharmacist. So that's happening in that part. But also, if you want to take your prescription somewhere else, you want to change your pharmacy, or you've got an acute prescription, or you want to purchase a medicine, then you can do that anywhere.
I will leave it at that just now. Convener, obviously, I might want to ask Community Pharmacy Scotland for some more, for their views on that when we have that round table. Thank you.
Just picking up on some of those themes of the Vice Convener, you know, and going back to the steering committee, you mentioned that there was a strategic role there, but not a role for the community pharmacists who are not on the steering committee.
So
Why would that be?
the community pharmacists are part of a group of many stakeholders. So the vision and action plan is about all pharmacists working across all sectors. So the directors of pharmacy are there in order to provide some of that input, as is the professional body. So other groups like community pharmacists will be represented through the reference group to be able to provide their views and opinions. And one of the things that the stakeholders said to us is that they want to be a sounding board to provide input into that. Now, the chairs of the reference group will also sit on the steering board. So they will have a direct route into the steering board in terms of raising issues that they may have. Community pharmacists, where we identify relevant, they'll also be part of the relevant working groups where there are work packages that need progressing around prescription for excellence commitments. They'll be part of those working groups which will actually be around the delivery of some of these areas of work. So they will be included where they needed in terms of the work packages and obviously part of the reference group.
I think the other thing is that we've had a number of calls to be on the steering group from the unions, from other trades bodies, and we feel that the role of the steering board is to ensure that throughout the Scottish Government and NHS that people are taking forward not just Prescription for Excellence, but delivering the 2020 vision. And the reference group is there as a critical friend, but is also inputting into the steering board and the core management implementation team.
And I don't know whether that answers it for you know, at least some of the members of the committee have already been vocal there. I mean, it just seems a bit, you know, community pharmacies and, you know, and their role, continuity, all of the, you know, to help deliver all of this, to feel excluded from that strategic body as...
They're not being excluded because they will be forming part of the working groups. And
But they were sitting in the part of the working groups with other trade bodies
well,
and trade unions, etc., etc. Are they not in the hierarchy of all of this? Are they? It seems a bit of a. It seems a bit strange to me that they you know, given their role in delivering much of this, that they would not have a say.
They will be delivering it, as will all the other pharmacists and some other healthcare workers. I think the thing about the steering board is it is there to look at policy as it changes and to make sure that the Prescription for Excellence is taken forward.
The chronic medication service, how many people are registered with those pharmacists?
That's a good point. I've got the numbers somewhere.
I think I asked for PQ on that a few weeks ago, so we should have a...
Oh, so you can tell me.
I think it'll be just about to come out.
Yeah. We'll look that up for you.
It's hundreds of thousands, isn't it?
Yes,
Directly linked with those pharmacists,
yes.
individual pharmacists, community pharmacists.
They're registered with all community pharmacists.
Hundreds of thousands of people are registered with those community
Yeah,
pharmacists.
380,454.
Nearly.
Yes.
You know. Does that not give them a seat at the steering committee?
In the sense that the steering committee is about the overall government policy, no.
Well, we'll probably hear more about that later.
Yes.
Rhoda Grant.
Thank you. Can you hear me?
It is,
Yeah,
it is now.
Can I ask about remote rural areas? As you'll be aware, there's a lot of work going on about community consultation and the like about opening pharmacies to allow communities to have a say in that. That consultation, however, does nothing to address the lack of pharmaceutical services in remote and rural areas and how we can actually allow people to access them without destabilising existing GP services. Is there any work ongoing to look at that?
As you know, we did put out a consultation and that is being looked at within the department now. And the results of that consultation and the department response will be out later. But we have been talking to an island board who are very keen to look at the role of the pharmacist working with dispensing doctors. And they are away now building up a programme for a project so that we can actually test pharmaceutical care in a dispensing doctor area so that the patients will have access to the pharmacist.
When do you expect that to take place or to commence?
Right. they're away now working on this, and can I say very supportive. The medical and administrative staff we met, and we would expect that we would be able to go public on this after the government response to the consultation comes out.
So when the government put out their response to the consultation, you hope that the government will be able to announce a pilot scheme. Am I able to ask, I think I know which health board it is, because I've been pushing them and I think they're all in my area as well. But are you able to say which health board area it is, and also the time frame for a possible pilot? Because I think people are missing out on services, and you know, as the conflict between pharmaceutical services and GP services continues, I think people will kind of not be receptive to pharmaceutical services and thereby missing out.
Yeah, I mean, I would like to tell you which board this is, but we've kept this quite close at present. And I'm rather hoping, once I've cleared this with the board themselves, this will go in the public domain.
Okay, and the announcement will coincide with the announcement on
It'll
the
be
current consultation?
very near it. What we've asked them to do is to send in a project plan and some costings, etc. And once we get a look at that, then we'll be able to move on with this.
Include direct patient interaction with pharmaceutical services?
That will include the pharmacist having a case load of patients who are, in the doctor's opinion, perhaps of complex medicines and things like that. So it will be very similar to the pharmaceutical care that we would want to offer in other areas.
Okay. I suppose part of my concern about the lack of pharmaceutical services in those areas is not so much the complex care offered by pharmacists, because my understanding is that GPs can access that through their health board and have a review of medications and the like currently. I think what worries me is Joe Bloggs walking down the street who has a minor ailment, who wants some advice about what they should do about it, and maybe doesn't have the time or the energy to go to their GP and wait for an appointment, because so people ignore those kind of small minor ailments because there is not a service available to them. While I know it's very important that GPs have access to pharmaceutical services, I think it's equally important that individuals have access to those services as well.
Okay, let me take that back then. And I mean, essentially the first thing was we wanted the pharmacist as the pharmaceutical expertise to engage with the local doctors and the pharmacists. We were not looking at the minor ailments at this stage.
Gil Patterson.
Can I talk about public awareness? And we're aware that the committee is that Dr. Barber and Professor Wilson in their report have highlighted the need to engage with the public, to inform them, to keep them up to speed on the relevance of this. I think that's a big job, so I'm wondering what action that the government is taking to inform the public of and get them on board and make this happen.
Yes, that's a very good question. I'm going to ask Alpna if she would care to answer it.
Thank you. I think one of the first things that we should say is that through the Alliance, we had a facilitated day with key patient groups, and we shared with them the same presentation that we've shared with key stakeholders around prescription for excellence. And from that piece of work, Ian Welsh, for example, he's on the steering board to make sure that we actually engage with patients and we bring the patient voice to the table. And again, we anticipate that Irene Oldfather, who again leads the Alliance, would be part of the reference group. But an important piece of work going forward, and the messages that we heard from the public groups, were that they wanted to work with us to raise awareness amongst patient groups and amongst patients about the role and the direction of travel of the role of the pharmacist's input into their care, particularly around complex medicines. And one of the things that we have agreed with the Alliance is to work with them and have agreed that we'll set up a memorandum of understanding where we'll set up a patient liaison worker that will work with us to work with different patient groups across Scotland to undertake pieces of work as we go forward. And a bit like doing a think piece as they've done with health and social care integration, so that they can help produce literature that can help patients understand the role that pharmacists can play. And we think that that's really crucial, because actually the patients are saying to us, we need to know more, but actually we need to tell our wider audience more about the role that pharmacists can have. So that's a piece of work that we'll start to do with them, and they'll be working with us very closely to make sure that we deliver the key messages and take on board the patient voice at all points in our journey. One of the other things that they very clearly said to us is that they wanted to be part of the working groups. So as we put together new packages of work, new ways of delivery, the patient will be there at the centre, helping inform the direction of travel.
In equal measures, maybe even more importantly, fellow professionals would be required or encouraged to engage and to help this process. Has there work been done to action that within relevant fellow travellers in this area?
I think that in terms of our work programme, these are the things that we will talk about in how we engage with the public, and what sort of literature we are going to have, and we will have the Patient Alliance there to help us understand what the public are actually requiring.
I was just going to add, I think one of the things that came from the healthcare professionals that are on the steering board, which are, you're asking about engagement with fellow professionals, is their willingness to actually take the vision and the message out to their key professionals. And indeed, we heard from the medical director the need to make sure that they take the message out and share it with their secondary care colleagues. So they've undertaken to do those pieces of work. We're also working with RCGP as well, who will represent all the other Royal Colleges as well, and nursing, so to make sure that we do engage and work with our healthcare professionals, but also we need to do that with our social care colleagues as well.
You kind of second guess my next question. That was, what's the supportive elements? Is it encouraging from other professionals? Are they on board? But you've answered that question. Thanks, Convener. Okay, fine.
Can we look at the issue of workforce planning? How many pharmacists are there in Scotland?
There are about 4,200 or so pharmacists. The workforce planning, we want to look overall at the whole of primary care in workforce planning. Because in order to move ahead as we want, which is wherever possible you get treated and cared for in your own home or your own community, we have to think about what the dynamics are for that in terms of secondary care as well. Because one of the things that when we say and acknowledge in Prescription for Excellence is there are some medicines which are now available which were only prescribed by hospital physicians and consultants, which the patient can now be in their own community, still under the care of that consultant. And what we want to do and need to do is to bring the integration of the hospital pharmacy specialist with the community pharmacist and with the GP, so that we're looking after that patient in the best way possible. So it's the overall workflow and manpower planning that we shall be investigating. And we have asked for NES to help us with some of that workforce plan.
So have we got too many pharmacists? Not enough, maybe, you know, not enough pharmacists. Is the number just right, or?
That's a difficult question. I think we are now seeing unemployment in pharmacy because not in Scotland, down in England, they have opened up a significant number of new schools of pharmacy. And also, with our links with Europe, pharmacists in Europe are entitled to come over and practice here. So we are probably at a stage that we want to look at the intake of pharmacists into our pharmacy schools, and that's certainly going ahead with the Department of Health down in England.
What are you doing here? You just watching what's going on down there, or are you is there a work stream that you've initiated? Or?
No. What we did was we wanted to identify why we need pharmacists and what we're going to use them for. And having done that, that will inform how we are going to limit the numbers in the educational programme, if that's the best way to do it.
So I suppose that lies behind it in terms of the next question of the mix that we've got.
Yes.
We've got community
Right.
pharmacists, and mentioned clinical pharmacists. So there's a mix. Are the pharmacists in the right areas? Is there an imbalance there? Is there too many in the community? Is there too many? You know.
Right. I think there's.
What
there's
have you found with
Yeah.
with your work in that area?
There's two things, Convener. One is that some of this work, if we are going to dispense 90 million prescriptions a year, supervise substance misuse, etc., we have to look at the whole skill mix within pharmacy, the pharmacy assistants, the pharmacy technicians, and the private sector, and you can see from the CPS submission, the private sector regard their manpower as confidential. And I think what we have to discuss with the private sector is, if the bulk of your work is coming from the NHS, then we will expect to work with you and to get that information.
But I nearly went back to that steering committee about these strategic issues and why they're not, why some of these people are not there in terms of what we need. Pardon?
Sorry, I was going to come in a supplementary one.
No,
Yeah.
you're fine. We'll do it. I was just trying to, just take an idea of what sort of thinking was there for the future. Because we've had these discussions. This is not unique to
Yeah.
pharmacy. We've had these discussions in the health service about what then.
Yes.
You mentioned technicians and others, and what will the pharmacy workforce look like in 10 years' time, or 20 years' time?
The pharmacy workforce could look like, and of course this is why we've got the work programme, but it could look like that prescriptions will be dispensed for routine medicines, not in the pharmacy at all, but in a hub, using robotics. and that the clinical pharmacist will be spending time patient-facing most of the time, and that there are other members of staff that work in pharmacies, and we would see them. We've in fact funded some courses for what we call pharmacists' assistants, and what they do is they will collect the information for the pharmacist before the pharmacist then engages with you. So I think it could look quite different from what it does today.
But with the robotics, how would that be then? I mean, I presume that different groups of people would be treated differently within that process. People in chronic medications would get more patient-facing stuff, or what?
I think,
would it be just like going online and, you know?
I would just say that this is one of the work streams that we want to consider and that we're going to consider fairly early on, and that we are planning to have some pilots that we will run, which will work with health economists and our colleagues in Capital to do some work around modelling, because we already know that there are pharmacists already that use robotics within their pharmacies, and we've learnt some lessons from them already. But actually we want to undertake some pilots to look at different models, different communities, and to see how that might work before we come up with this is the way. And I think it's important to take the time to do that, to find out what works for patients, what works for pharmacy, and what works for the workforce. Because we're proposing this as a means to release capacity to deliver clinical care. So we need to do some health economic modelling, which is what we have planned to do in the next couple of years, to try and put that in place, to gather that evidence and that data that we need. And again, this is something that we would very much hope that we will work with our community pharmacy colleagues across Scotland to do some of the pilot work and work with the health boards to maybe identify suitable pilot sites and models.
Have you got some proposals about pilots you're going to put to them, or will they help you develop those pilots? Or
they will help us develop the pilots.
Bob, you've got a supplementary, and I see Richard's got a supplementary, and Dennis, is it a fresh question? Or, well, I'll take some of the supplementaries then on this sort of theme.
Okay, thanks, Convener. I actually think you, Professor Scott, you asked a question that you'd have been well not to give a huge amount of detail on, given the fact that we're going through a period of change. And I know you said what the pharmacy could look like in 10, 15 years' time, rather than what it would look like. And Ms Mayor talking about the idea of a working stream in relation to this and drawing in all the professionals. And I'm just doing this into the working stream and the steering board. So the working stream, I would expect to see clinical pharmacists on it. I would expect to see community pharmacists on it in that mix. Is that right? Yeah. Okay, well, the next thing that's screaming out at me would be the idea of what we've done within the NHS, although pharmacy is not the NHS. There's contractual relationships there, or not, as the case may be, in relation to, say, workforce planning tools for nurses, where you map out where nurses are in the community, where they are in the acute sector, where they are at A&E, where they are in elective surgery, where they are in mental health, and then you have to, you come to a number that you need. Yeah. That feeds into the training. I know, but okay, I know the convener's saying question. What I'm trying to tease out is, do we need a workforce management tool, a workforce planning tool for pharmacists, not just community pharmacists, but all of them? And can we develop that just now, or do we have to wait until what pharmacy is going to look like in 5, 10 years' time is teased out more? Because we could develop a planning tool now which would be fit for pharmacy today, but if pharmacy is going through a period of change, when would we expect to see the work done on that? So I'm sorry, Convener, for the kind of long lead into it, but I think these are really important if we're going to plan ahead in a professional manner.
I can take that point, and in fact, we have someone here from NES, which we'll be speaking to later. But NES have been doing some good work with dentists on workforce planning. And we have a workforce planning team within Scottish Government, and we've had early discussions with them about how pharmacy can be built into their work schedule.
Okay, and just for clarity, I'll just ask this,
It's
this
a
time, Convener.
supplementary, remember.
I know, but just for clarity, that doesn't presuppose the working stream on pharmacy workforce planning that we expect to come from the steering board. It will work in tandem. We have to make sure these two things work together, not in silos.
And I think they will, and that's part of the purpose, is that work stream will report back up to the steering board, and it will link into relevant policy areas, which means the workforce group within Scottish Government. I think the other important bit to just, and you touched on it, is that actually, as well as the workforce, and others have raised the issue, is we actually need to look at what the needs of the population are in a particular locality. And many of our pharmacist colleagues within Health Board, the public health pharmacists, have started to develop mapping tools so that we can identify what kind of services for what kind of patients, and then we need to build our workforce around that. And health boards have a key role in that. And so again, we need to work in partnership with our health boards, and we've already started to have some of those conversations with them and drawn on the really good pieces of work that they're starting to produce. So it's important to make sure that our work streams also dovetail, and we'll make sure that we do that as we go forward.
Thank you, Convener.
Just to put it on the record again, we do it, regularly at this committee. We are supportive and recognise the need to change the health service in all its parts to deliver effectively for the people of Scotland. We're not divided in politics on that, but that doesn't absolve us from asking the questions here about what the clarity that's being presented. And if we've developed a strategy and we're not clear in the workforce we need to deliver that strategy, I don't know where that's cart and horse, but that's what we're trying to get at this morning. So Richard, you're going to, is this a supplementary on this? Or?
I think, well, it's about safety and robotics and waste, so it's maybe
We'll
slightly
maybe come back to
different.
that then and,
Yes,
and let Dennis answer this question
Thank you very much, Convener.
and ask his question.
Keeping the patient at the centre, how close should the pharmacy practice be to the patient? And, is there a differential between an urban and rural? And Rhoda Grant mentioned the remote and rural areas. So ideally, how close? Is it based on population size, or is it based on sort of location? Have you thoughts around that?
The way in which the pharmacies are located just now are really historical and based on market forces. What we want to look at is, in our planning, and the boards will start to look at population needs and then match that with the service. Now, that means that we will have to start to look at new ways of planning services. At present, we have the control of entry, and that's very much driven by the market. What we're asking health boards to do is, by using the planning tool, identify where the vacuum is, and then to make arrangements to have that vacuum filled.
Do you envisage then a relocation of some pharmacy practices as we go?
At present, the pharmacy practices can relocate if it's a minor relocation without going through any long process. But we're asking the boards to take more responsibility for where they're placing their services. And I think the other thing I should say is that we imagine all patients go to a pharmacy. In fact, as you get older and infirm, it's your home that you're based in, and it's how the pharmacist will be able to engage with you, either through your carer or by themselves.
Oh, thank you. Thank you, Convener.
I think just you know, we will also be looking at technology and how we use technology. So we already have good examples of how technology is used by other healthcare professionals, and we want to make sure that we look at that for pharmacists delivering clinical care to optimise the benefits for patients.
Available within some of the remote and rural areas as well, of
That's
course.
right.
Thank you, Kevin.
What other barriers have you discovered in, you know, in that innovation that do you anticipate that you need to overcome?
Barriers to the use of technology.
Well, the technology and the examples that others are using. I mean, I take it that's a bit of a workforce issue as well in terms of getting people on board and accepting the changes necessary. Or?
I think one of the things that we know is that NHS 24 have done key pieces of work around the use of technology, and so we would hope that as we go forward, we've had initial discussions with them about how we might work with them to learn the lessons that they've learnt and look at how we can then facilitate pharmacists to access that technology. So it's really important that we actually work with them who have already had the experience of implementing some of the technologies and look at how we can facilitate pharmacists to also use this technology.
Okay. Before I take Richard Simpson again, Jackson Carlow wishes to ask a question.
I've sort of been listening carefully. I have to say with a mounting sense of a lack of enthusiasm. There seems to me a tremendous capacity here. If something can turn out to be a complete shambles and a muddle, in my experience it invariably does. How are you going to preclude that being the outcome of what you're proposing?
Well, if I can say already, since we have put this document out, there is a great deal of enthusiasm, and we have been approached to help us develop models. So I think some of this, we have to allow health boards to try some of these things out so as we can learn from success or stop for failure. Sir Lewis Ritchie, who is chairing this, is going to keep with his steering board a very, very tight rein.
Well, I'm reassured by that. I just concerned as I've listened to it, so with a sort of business background, at the kind of multitudinous areas where it seems to me it could all go slightly astray unless a very tight grip is kept upon it, and there is a flexibility of action as it progresses, so that in the event it becomes apparent that something that seemed like a lovely idea is now having a very negative impact in its consequence. Something is done before it ends up being something we then all have to come back here and investigate. Whatever this general support for the principles, it's the delivery of them that seems to me at the moment to be quite fluid.
That's exactly the conversation which went on in the first meeting of the steering group.
Okay, thank you.
Richard Simpson.
Yes, you mentioned robotics, and you know, I think that's part of the future. Royal Larbert has a fantastic robotic system which has improved the interaction between the clinicians and the pharmacists. It has reduced waste enormously. It has reduced the capital required for storing medicines, because the whole thing has actually made a hugely efficient improvement. Now, in a sense, community pharmacy, although it has multiples, is still at the stage that general practice was at 20 years ago. It's still very much an individual shop outlet, marketing, all sorts of things. Do you see a role? The other part of this is we've also known from recent research, as you'll be aware, that the error rate on GP prescribing is not insignificant. Fortunately, most of it is not serious, but nevertheless, there is a fairly significant error rate. So I just wonder if you'd like to take us through a little bit about three aspects. One is the role of the NHS as opposed to the private multiples in terms of the potential for robotic prescribing and interaction with the private sector. The second thing is the effect upon safety and how you see that developing with the strengthening of the pharmacy role to ensure that errors are picked up and corrected. And the third thing is what you see as the impact on waste. And behind all that, what research and monitoring you're going to do, because we're learning as we go along, as Jackson Carlo's question actually made very clear. We are in a relatively fluid situation where you're going to be testing new models. And unless we do really good research on these, really good audit and monitoring, we could end up in a bit of a guddle rather than actually developing models which really are world leading, which we have, I think, the potential to do.
Yes. I think there are, certainly in Holland, I know that Wilson and Barber had a presentation from a robotic dispensing company who I think have something like 3 or 5 robots serving a huge population. So we have to learn from their mistakes as well. One of the roles of the NHS in this, of course, these services are delivered on behalf of the NHS. So there has to be an oversight by the Director of Pharmacy, the IT head, to ensure that whatever we're doing, we're putting through our e-health programme, for example. And we've had a very good relationship with the e-health programme, and our e-pharmacy programme links in, and the e-health people sit on the e-pharmacy programme. So we are conscious that we don't want to invest in something that, as Jackson Carlo mentions, just is a waste of money. So learning from others, working with e-health, and the work that was done in Ayrshire and Arran with their computer system hospital prescribing demonstrated that they started to reduce the number of errors.
Could we get a note on that, Chair? Just it would be helpful to have a, not just now, but I mean.
Yes, it'd
be helpful.
I'll
just
get
to
Ayrshire and Arran to
thank you.
give us a report. Impact on waste. I don't think any of us in the medical fraternity want waste. We would rather have that money used for better patient care. There's a number of areas that we are looking at for waste. One of them is the Scottish Therapeutics Utility, STU. This is a computer software which will help GPs identify potential areas for waste. So looking at the number of prescriptions that are being written or what have you. But also I'm going to ask Alpna to maybe say something about waste.
Okay, so you talked about research and particularly the York report that looked at the research on waste, and one of the things that it identified as a key was that in order to reduce waste you actually need to have a systems approach, and central to that was proper medication reviews and working with the patient and improving adherence. And that's really exactly what we're proposing to do with Prescription for Excellence. And we've built that on lessons that we've learnt from work that we've already done to date. So say, for example, the polypharmacy work, so identifying patients who are on multiple medicines and found the interventions that we can have in that, which not only reduces the number of medicines that people are taking, that's a side issue. The most important issue is that actually we improve safety for the patient and we reduce harm to the patient. So that they're the really key focuses that we've had in terms of reducing inappropriate prescribing. And the research that underpinned the support of pharmacists working with GPs was illustrated by the Pincer trial, and that showed, and we used that as a reference for when we put together Prescription for Excellence. Audit Scotland report into general prescribing, made the similar recommendations, and that's really where we've taken the evidence and built on that as we go forward for Prescription for Excellence in building capacity of pharmacists working with our GP colleagues to look at prescribing, to look at management of patients, so that we can prevent the problem of waste. We can help support patients to appropriate prescribing, to adhere with appropriate medicines.
Thank you.
Colin Kerr.
Thanks. It's just actually a little bit more on this, relatively new to the committee, and maybe a little bit of background, but in terms of the referral, or perhaps pharmacists having access to medical records and stuff like that, I'm told that there are some fundamental difficulties with data protection and various other things for the novice amongst us here in terms of this. How are these difficulties identified? Is there any resistance to change here, or is there any position that we can find ourselves in the future where there's perhaps a freer flow of information, and how do we maintain that, keep people on board?
Yes, there has been resistance in the past, and even in the hospital sector it took a long time before hospital pharmacists could get access to the case notes. But we are all healthcare professionals bound by the regulator and code of ethics. So there's not particularly confidentiality gene that you get when you become a healthcare professional, but there is a code of ethics. At present, if a pharmacist is involving themselves in a polypharmacy clinic, they will work within normally the GP surgery, GP practice, where they can have that access. But you can see from the evidence that's come in from others that actually getting access to patient information would make the whole system a lot safer. And to do that, we've got to get agreement from our medical colleagues, and we have to have systems which assure the patients that they've got confidence that that information, if it goes into a pharmacy, will not end up in the head office for them utilising for other purposes. And that is the conversations that we are having and will continue to have.
Thanks.
I was interested in this, the Dutch model that's dispensing for vast amounts of people, and the earlier discussion. So, sometime in the future, I go to the GP gives me electronic prescription that goes to the robots down and I go and pick it up at a central point. Is that what would happen?
That's what would happen.
Is that what happens in Holland? Is that
in Holland? I would have to check and come back to you on that.
Is it in-house, or is that contracted out, this service?
This is a company who are actually providing
so it's not
the service.
In-house health service thing. They provide just those services on a bigger scale.
Yeah. I will go back and check that with Barbara Wilson's notes.
Has there been any calculations in the savings that would bring about for the health service in Scotland about the delivery and using that method?
We haven't got those calculations, but clearly if you do things on a larger scale and you have a more efficient system, then that will or should produce savings.
And the basic investment would be provided from the private sector anyway when they set up this robotic. There was no the health service wouldn't incur any capital costs.
Yeah.
They would do that, would they?
I think.
I think one of the things that we'll be informed by will be the modelling work that we'll do with the robotics, and I think that that's key, that we take that work into consideration, because that will identify some of the issues, because one of the issues that we need to take into consideration in Scotland is some of our remote and rural communities. So balanced against the central hub, we might need to take into consideration things like transport costs. So I think it's really important that we take into the work and the considerations and the findings of the pilot works to help inform our thinking, because it's really relevant that we make it relevant to the public that we serve in Scotland. So it's important that we see the outcomes from those pilot studies.
But again, we've brought forward a strategy that is based on some thinking.
Yes.
You know, but in the you know, in the cities or you know, Glasgow and Edinburgh, there would be no such constraints.
What we've said in the vision is that we will work with providers to look at the economics of the utilisation of robots. And I think where we're at this moment in time, we are gathering together the groups of the experts that we will require, and we are looking to how we can work with providers to perhaps do some sort of joint project.
How far is that down the road? Has that just been a general discussion with these providers, or?
We've had some initial discussions internally with our capital colleagues and also with procurement, because they have to, we're procuring robotics, we have to go through official processes. So we've had the initial discussions about how we go through that process to engage relevant stakeholders.
Is there a number of specialists in that field? You know, I mean, is there 2 or 3 companies or major companies that are dealing with this on a worldwide basis, or is there we've drawn on the expertise of our procurement colleagues who tell us that there is a worldwide market out there, and what they would do is they would take the normal processes and challenge to make sure that they go out to the relevant companies to tender, so to lay out specifications and for companies to come forward with what they can offer. So I think it's the advice that we've been given would be about us following due process to make sure that we get the best possible input into the pilots that we're going to put forward. Have you looked at financial comparisons and what you would expect to?
That's one of the pieces of work that we would want them to do. So some companies have shared with us things like return on investment, some mapping work that they've done. So part of the pilot work is actually to do that piece of work. So in terms of the return on investment, in terms of releasing capacity for pharmacists to deliver face-to-face role, they are the things that we would put in the spec of the pilot work.
In terms of your title, you've both got a financial responsibility as well, so it's not went any further than notional figures. Is there an expectation about what savings can be made if we go down that route?
Well, we work in the division which is headed at the directorate, which is headed up by the Chief Finance Officer, and he would not let us do anything without making sure that we went into the economics and finance of this.
None of that work been done at all. If we ask for that, there's none of that work been done at all.
That's part of the work that will take place in terms of the pilot work and looking at what capacity that we can release.
There was just another one here. I don't know if there's anyone else got any questions following that Richard's wanting about it, but it was just the issue. There's, in the world that we live in here, it's all the constitutional reserve powers and devolved powers, and the Royal Pharmaceutical Society has indicated in their submission that there would need to be looking at that in terms of control of entry, regulation, and current legislation. Just to ask you today that what stage you are with that, is that in the wait and see category as well?
The control of entry is a devolved matter. for the NHS, and that's what that consultation is about. But the medicines legislation is a reserved matter to the MHRA, and Alpna might say where we are with that at present.
Okay, so there's a UK piece of work that's around looking at balancing regulation between law and professional regulation in order to try and cut some of the red tape around this. And although it is a reserved matter, each of the devolved administrations are represented around that room so that we can share the issues that we face in our own countries in terms of delivering healthcare. So I sit on that group, and one of the things that we feed in is actually the direction of travel that we want to go in with Prescription for Excellence, and the opportunities to change some of that to enable pharmacists to deliver a more clinical facing role. So that work is already undertaken currently, and that work is progressing. One of the key pieces of work that's being progressed just now and that's starting to look at, and again we contribute to that and have a seat at the table so that we can discuss the issues that are pertinent to Scotland, is around supervision and how we need to deal with that as we go forward so that we can address the issue of pharmacists being able to be away from the pharmacy if that's appropriate to deliver patient care. So we need to have that discussion, and that work's already started as part of a UK-wide piece of work.
Okay, thanks for that. Richard Simpson, I don't think there's any other questions. This is the last question.
Just a very, very quick one on minor ailment scheme, which has now been around. I had conversations with the First Minister of Wales at the time. They introduced free prescriptions and asked him if he was going to introduce a minor ailment scheme. And they said no, because they thought it would be far too expensive with free prescriptions. Now, we've retained the current registration system that requires you to go back to when we didn't have free prescriptions in order to register for minor ailments. So we haven't modernised that system yet. And you hinted in an earlier reply, Professor Scott, that it was to help, I think you said, families, young families and people on lower incomes. Has the time not come for us, on a cross-party basis, which we're now beginning to talk about, to actually change the minor ailment scheme in some way to make it available only to those with low incomes and families, rather, or to take the additional costs of making it to everyone, but get rid of the bureaucracy, which means you've got to register still. You know, if you're diabetic, you can get free prescriptions. If you're a new diabetic, you can get free minor ailment scheme, but you have to go through a registration process that you would previously have had to do when you didn't get free prescriptions. Sorry, it's a bit long-winded,
Right.
but it's a technical.
The registration process was to stop even more bureaucracy in looking at bits of paper and who is using the service from different pharmacies, maybe collecting lots of paracetamol or whatever. So the registration tool is a good tool, and it also tells us the use of the service. But in Prescription for Excellence, we talk about moving to common clinical conditions. And the reason that at the beginning you said every pharmacist a prescriber, pharmacists who are prescribers, if we had common clinical conditions, could actually be taking some of that workload away from the general practitioner to allow them, so that pharmacy would be seen as that first port of call.
So you see that as taking over from minor ailment scheme in the long term?
I would see that that we would move to that. We, of course, will have to look at the costings and how that would work.
Yes, because I think our minor ailment scheme costs about 18, 20 million pounds a year at the moment. But it is limited to, in a rather odd way to certain people.
Yes.
I mean, if you're suffering from schizophrenia, you can't get the minor ailment scheme unless you also qualify on the grounds of either age or or finance.
Yes.
So if you happen to be someone who's able to work and has an income of more than 16,000, you can't get it. Is that correct?
If you're able to work, I think it wasn't if you're able to work, it was if you were on
An income.
an income
Yeah. Thank you.
support.
Just an aside there, you mentioned earlier about a name change to the chronic medication service. Are you looking at that in the round here with...
I think
it's no more than a name change. I suppose that's
No,
what
it-
I'm suggesting.
well,
Well, there is.
what we're saying is that
Yeah.
in prescription directions we talk about long-term conditions, and that is where we would look initially. But we hold discussions with CPS and others regularly, and we do make changes to the chronic medication service by adding other parts onto it where it is appropriate.
So is it just a name change, or I'm just looking at are you looking at that more fundamentally than just a name change? Are you bringing these things together, or?
I think that is a name change initially, but what we want to look at as we have clinical pharmacy prescribers is how they then engage with their GP colleagues. We've got some very good examples, and you've got good examples in the evidence of pharmacists working with GPs, running clinics for long-term conditions. And in fact, some of our advice that we've been getting on this comes from our own senior medical officers in the department. And one of them did say, if any member of the committee want to go and visit his deep end practice in Glasgow and speak to the pharmacist and himself, it might give you in-depth understanding of how they're working together.
I suppose the state question then is a chronic medication service continuing in its present form?
It is at
Yes.
present.
Okay, thanks. Thank you both very much for your attendance here this morning, the evidence provided and all the time you've given. We appreciate it. Thank you very much. We suspend at this point and set up for the next panel. Been to return to agenda item number 2, Scottish Government's action plan for pharmaceutical care. And we're now moving to a round table set up now in this session. It's a big table, lots of people here. At this point, we normally introduce ourselves. My name is Duncan McNeill, convener of Health and Sport Committee, MSP for Greater Inverclyde.
Hello, I'm Andrew Buist. I'm a GP in Blairgowrie 3 days a week, and 2 days a week I'm a Deputy Chairman of SGPC of the BMA.
Bob Doris, MSP for Glasgow and Vice Convener of the Committee.
Martin Green, community pharmacist, community pharmacy owner of a small chain of pharmacies in Glasgow, Chairman of Community Pharmacy Scotland and member of the Scottish Board of the Royal Pharmaceutical Society.
And good morning, Dennis Robertson, MSP for Aberdeenshire West, substituting for Richard Lyle this morning.
Jackson Carlow, MSP for the West of Scotland, Conservative spokesman on health and substituting for Nanette Milne.
David Flegger, Director of Pharmacy for NHS Grampian.
Colin Keir, I'm the MSP for Edinburgh Western and member of the committee.
John Cromarty, Chair of the Scottish Pharmacy Board of the Royal Pharmaceutical Society, former Director of Pharmacy at NHS Highland, and I have a visiting professorship at the School of Pharmacy at University of Strathclyde.
Gil Patterson, member for Clydebank and Mulgai.
Norman Lanigan, I'm acting head of the Pharmacy and Prescribing Support Unit of the NHS Greater Glasgow and Clyde.
Aileen MacLeod, MSP for the South of Scotland.
Stuart Irvin, I'm the Medical Director from NHS Education for Scotland.
Richard Simpson, MSP Mid Scotland and Fife.
Mike Pratt, Director of Pharmacy for NHS Dumfries and Galloway, representing the Directors of Pharmacy in Scotland.
Rhoda Grant, Highlands and Islands MSP.
Miles Mack, I'm a GP in Dingwall, North Scotland. I'm here for the RCGP Scotland as Deputy Chair Policy.
Thank you all for that. And we move quickly now to Gil Patterson, who's going to set us off, aren't you, Gil?
Yes, just a fairly straightforward question to get folk engaged. And it's what benefits has a previous strategy, that's the right medicine that was enacted in 2002 by the previous Scottish Executive, brought to the delivery of pharmaceutical care services, and how do the witnesses believe the new strategy can be built upon?
Who wants to take that? I'll take it. It's come right round. Andrew, do you want to?
Yeah, I'll make a start. I mean, as Professor Scott said earlier, it was a move away from the purely dispensing process, public health, minor ailment and chronic medication service, which GPs have engaged to a certain extent on. We don't think it's the finished article. There are still a number of problems with it. I've got about half a dozen to 10 patients on it, and 2 of them have asked to come off it for various reasons. We find it inflexible. I think in terms of prescription for excellence, in terms of moving on, I think there are huge opportunities within this document, and we are positive that there is a great opportunity to improve the quality of patient care in the community in line with the 2020 vision, to integrate our care, to share data. I think it can give increased job satisfaction to the pharmacist. There are opportunities for joint training of doctors and pharmacist students. And as been mentioned earlier, it could help with the GP workforce crisis which we are facing, because GPs are in short supply just now. As I said earlier, I'm a GP in Blairgowrie, and we have been fortunate in NHS Tayside. For 12 years we have had a practice pharmacist, and he is a member of our practice team. He is a member of our practice 3 days a week. And he has been enormously useful in improving the quality of the care that we provide to our patients. Giving you some examples with medicine reconciliation when patients are discharged from hospital, liaising with the community pharmacists, leading on medication audits, polypharmacy reviews in nursing homes, compliance with health board formularies, evidence-based advice on complex medications, and advising us on best practice prescribing. In short, he's reduced our errors, increased our compliance, increased our cost effectiveness, reduced our waste, and reduced our variation. He's increased our quality. But I think there are, as were alluded to earlier this morning, challenges in this proposal of ideas. Data sharing is one. I don't think that's insurmountable. Costs are another. I think robots are mentioned in the document, but I don't know much about them, but I believe they come with large price tags, certainly tens of thousands, possibly hundreds of thousands, and they need purpose-built premises in which to operate like they have in Larbert. And as Richard Simpson alluded to, the pharmacy multiples are going to be a challenge, and I think not enough thinking has gone into that. And finally, I think there are also some threats within the ideas in this document. And as Jackson Carlo said, there is a real risk of a muddle here, of unintended consequences. I think a key thing, and I want to see this, I want to see pharmacists and GPs working together in the community, but it's essential that they work together as part of an integrated team. If they're working in different silos, separated apart, there's a real risk of confusion of care, who is in charge of the patient care. And IT, if we can get it to work, can help to a certain extent, but the model that I am fortunate to have in Blairgowrie works because it's my pharmacist in the same team, and we work very closely and share patients. And if we dissipate that model, there is a real chance of a muddle developing.
Thanks for that, Andrew. There's a lot of issues in there which were previously discussed. Miles?
Yeah, I echo a lot of what Andrew said. The simplistic way I see about interprofessional working, which I think is a key to this, is how pharmacy works with the rest of the NHS, is actually about three things: about being clearly focused on what the patient's needs are, actually being clearly focused on what our own roles are, and do we understand the roles of others, and actually how we communicate. I think there's a great opportunity to actually look at this, to be sure that the pharmacy skills out there are being used to the best. I'm not sure if they're always working to the top of their license. And actually the process of communication between the pharmacy and GP is absolutely crucial. We talk about the primary care team. I think in this situation it's far better to see it as a network. And GPs have traditionally been a major hub in that network that people come to us as a first point of call. I also believe that actually sometimes they're not necessarily using pharmacists as a point of access to that. And actually how pharmacists work, the huge opportunities in this proposal to integrate them better within the whole of the NHS and to allow them to signpost people correctly in the right way. Part of that signposting will be to general practice. We're aware of that. The common conditions cover a certain number of areas. The whole reason people come for professional advice is because they want to get some advice about whether it's serious or not. One thing that I think is going to be crucial is about how we provide decision support to each other. Andrew's given examples of how pharmacy can provide decision support to GP, provide specialist help. Equally, I think that should happen both ways. And it's not just in this dynamic between GP and pharmacy, but actually between pharmacy and the rest of the NHS primary care network.
Professor Donald.
I think just to pick up on that point, I think an important contribution to professional working is around interprofessional education and training, and that's certainly something which NES has been advocating very strongly, both at an undergraduate level with medical and pharmacy undergraduates training together, and also in some of the CPD packages that we deliver, where again we're trying to deliver joined up education and training for general practitioners and pharmacists being trained together.
Professor Lang.
I think when the first question was what's the right medicine made a difference to, and one of the things we did when in NHS Greater Glasgow and Clyde was to look at what we've actually achieved over the last few years. And actually I was really surprised to see how much of it is in line with Prescription for Excellence. So actually it's a continuum, I think, Prescription for Excellence. I'll give you some examples. We now have examples in NHS Greater Glasgow and Clyde. If you're a hospital patient, you now get your medicines from the bedside. They're in a bedside locker. They can support you taking your own medication if you're fit to do so. Our hospital pharmacists then share information with the patient's permission with the community pharmacist. And what we know is that 1 in 4 discharges, the community pharmacist makes use of that. So they might reinforce the message, a new medication that has been explained to the patient when they're in a hospital bed. Patient's really only thinking about getting home at that point in time, and the community pharmacist can reinforce the medicine about a change in medication. That kind of thing we know happens in 1 in 4 discharges. We've got a number of clinics for high-risk medicines like warfarin, which are either, depending on the setting, run by community pharmacists working in partnership with GPs, working in partnership with specialist pharmacists, and that's happening. We've got a clinic in Inverclyde which is looking at a reduction of inappropriate prescribing of antipsychotics, again working as part of the team. And also increasingly we're seeing pharmacists, which is something that never happened before the right medicine, seeing patients in their own homes, actually housebound patients, and doing reviews of their medication in homes. And indeed we've just announced an initiative with East Renfrewshire, and just recently has been started as part of the health and social care integration. So I think there's been a lot of activity going on, and I see the Prescription for Excellence as a vision that supports that continuum. One of the things that we want to do is to try and increase that integration. We've heard earlier virtual teams perhaps, but also real teams. It's the kind of thing we've had in hospitals for many years. Real teams working together, understanding each other's role, and respecting each other's role.
Michael Pratt.
Yep. I mean, I think Professor Lanigan used the term a continuum, and I think that's absolutely right. That's the view I have in my mind. I think the right medicine and the new contract in pharmacy allowed the traditional pharmacists to free themselves to some extent from the dispensing bench and much improve the direct delivery of clinical care to patients and increase the capacity within primary care. And I think that's been to patient benefit. I think the term continuum is absolutely right. I think the Prescription for Excellence takes us further along that road. I think the end point is quite visionary, but the next steps are really along the direction we were currently travelling. And I think it's important to recognise that. I think we've already heard this morning some issues around information systems and information flow, and I think that's absolutely critical. Certainly when I speak to pharmacy colleagues and medical colleagues within my board, that's one issue that's in their minds, is ensuring that the information flow exists so that at all points there is a clear understanding of the clinical care being provided to patients. And that is something we need to give careful consideration to.
Martin Green.
To go back to the original question, which was around relating it to the right medicine. The right medicine was actually quite prescriptive about what it wanted to deliver. And as people read it, they could see where their role was within it. And it was quite easy to define a set of objectives. And when you can see a set of objectives, it's quite easy then to plan for how you get there. So we really did have it planned and structured in which elements of it we were going to introduce first, so on and so forth. It introduced patient registration through the minor ailment service, which hugely increases access to medication. It introduced public health services, and through both minor ailments and the public health service, it began to set pharmacy out as perhaps the first port of call when a patient enters or accesses the NHS. Our chronic medication service was always going to be the biggest and most difficult element of the vision of the right medicine to implement. And we are not there yet with it. We are still very much working on it. It is entirely dependent really on moving to this almost paperless system. I say almost because in the first instance it'll still involve paper, but it's moving towards an electronic system, which again registers patients to a particular pharmacy. Where Prescription for Excellence differs is it's not so easy to define what we're trying to achieve and who is actually going to deliver it. Whereas the right medicine was very much a vision for community pharmacy.
Professor Cromarty.
Thank you, Convener. I think trying to address your original question about what's the right medicine done, I would echo some of the contributions that have already been made. For me, what the right medicine did, and we're 12 years down the line from that now, so it is time for a revision of strategy and a new look at what we should be doing. But I think it achieved a great deal across many of its objectives, and many of them have been successfully implemented. It has shown us models that work, that help to reduce the prevalence of iatrogenic disease, which is still unacceptably high. And we live in difficult financial times, and whilst we have some improving health statistics, we're not particularly effective at reducing iatrogenic disease, although the Scottish Patient Safety Programme has done a great deal in that direction within secondary care, and that's beginning to roll out into primary care. And you've already heard Norman talk about, for example, the management of high-risk medicines. So I think the right medicine did a lot for safe and effective care. I think perhaps it did rather less for person-centred care, and I think what Prescription for Excellence does is to focus on those high-priority groups, those vulnerable patient groups who increasingly suffer multimorbidities and are subject to polypharmacy. Therapy is becoming much more complex, much more difficult to manage, and I think it's essential, therefore, that we have the pharmacist as the expert in medicines as one of the key stakeholders in whichever teams are dealing with patients' therapy. So I think Prescription for Excellence is a natural progression from where the right medicine was. I think it sensibly looks at the need to get medicines governance as good in the community as we've succeeded in getting it within secondary care in some instances. We have excellent area drug and therapeutic committee structures and all the working groups that support that. But we need to get that governance working effectively in primary care and in the community as well, in places that we don't seem to reach so well with therapeutic input, like care homes, like patients who can't walk into the community pharmacy. And I think Prescription for Excellence prioritises our focus on some of these more vulnerable patient groups. What the right medicine has done already, I think, is that it's tested some of the models that helps improve patient care with the pharmacist's input. And I think what Prescription for Excellence does, it gives us a framework, quite an open framework, which Martin's acknowledged, but we're all going to have the opportunity to play in that network. So when the concept of the general practice clinical pharmacist is advocated within Prescription for Excellence, for me, it doesn't matter which location the pharmacist comes from to plug that gap. What we need is someone with the requisite clinical skills who's part of the healthcare team, strongly engaged with the GP in the management of that patient. But what they need to bring is the skills, the pharmaceutical care skills. Whether it's a hospital pharmacist, a community pharmacist or a primary care pharmacist, I think is less important. We actually need all three of those pharmacists to be involved, or we will not deliver this. And if we don't deliver Prescription for Excellence, the government will not deliver its 2020 division. It underpins 10 of the 12 priority areas of the action plan. So unless we get this right, unless we get the medicines management right, reduce waste, prevent some of the preventable iatrogenic disease, the 2020 vision is not going to be delivered. So this is really, really important. And, you know, okay, we weren't perhaps able to answer some of the questions that the committee rightly put this morning, but we are setting up a number of working groups that are going to test that, and we'll be in a position to report on that as Prescription for Excellence unrolls. So the profession, I think, is hugely excited by this opportunity. This is not just exciting within Scotland. This government strategy is the envy of national governments within UK and beyond UK. And we have a tremendous opportunity to make it work, provided we get effective models of care in which collaboration with the health and social care team works.
Okay. I mean, rather than go to questions for the committee, I give the panel members an opportunity to respond to some of that or what they've previously heard, if they want to do that. You don't want to do that, you get a committee member, and I'll ask your question, so. Okay, I think it's Rhoda.
Thank you. I am interested in how we deliver pharmaceutical services to communities in remote and rural areas. usually when pharmaceutical services are offered, they actually mean the withdrawal of GP services, and I think that's been hugely controversial in a lot of areas. How can we provide people, and I'm talking people, not health professionals, but how can we provide people with both services? How can they access pharmaceutical services without actually damaging the GP services they have and need? You know, if there's a hierarchy of need, they say GP services first, but then they miss out on pharmaceutical services. How do we do both?
Anyone want to? Michael Pratt, thank you.
If I start by saying I don't have an answer, but I mean, it'll be interesting that I come from Dumfries and Galloway. I have a large number of dispensing practices as part of our community. And 3 years ago, within our pharmaceutical care services plan, I wrote in a challenge that we needed to get pharmacy and general practice to work in partnership to try and deliver a full service to those rural localities without losing the dispensing doctor aspect, or rather the medical aspect that is required. And I have to say that we failed in that objective within the plan because we couldn't come up with a realistic solution. But I think there are opportunities as e-health systems develop, as telehealth systems develop, and information flow improves. I think we need to explore those opportunities so you can effectively have remotely delivered services to these localities. And that's a model, or models, that we need to test under Prescription for Excellence. You're absolutely right, we do not want to lose the medical services, put at risk the medical services in remote and rural communities, because they are absolutely essential. But we need to provide a full range of services to those communities as well.
Anyone else? Professor?
In direct response to your question, Rhoda, I'm from the Highlands, and last week we held an S evening with 10 VCing sites from NHS Shetland, NHS Orkney, NHS Western Isles, and 9 sites in NHS Highland. And I was very gratified to hear some of the proposals for early work on Prescription for Excellence that came from round that patch, and that's a large part of remote and rural Scotland. And a number of pharmacies, community pharmacies and managed service, have been approached by dispensing GPs to ask how the pharmacists could work more closely with them to provide pharmaceutical care to patients. So if we park the dispensing issue, on which there's a lot of red herrings and a lot of misinformation, and it's not really the focus of the debate. The debate is how do we get pharmaceutical care to patients who don't see a pharmacist, not where do they get the prescription from. So I'm very heartened by the fact that some of the initiative is coming from dispensing GPs who recognise that they can improve the care of their patients by gaining the services of a pharmacist into the practice. And we're looking at some outline proposals for telehealth type consultations where the pharmacist might be remote in the centre but would VC in to a patient consultation to give their pharmaceutical input at the point of prescribing, or indeed the point of polypharmacy or medicine review. So I think we can find systems that will work, and through which dispensing GPs and pharmacists from any of the sectors can work jointly. The particular project that I think is moving forward involves a dispensing GP practice in Skye and a community pharmacy in Skye. But we heard similar approaches from Orkney and Shetland and from elsewhere in Highlands. So people are looking at ways that we can manage this. And whatever the debate about who dispenses, when there's an application for a community pharmacy and there's an existing dispensing GP practice, we will have a very large portion of Scotland in which there will be no application for a community pharmacy. So we still have the problem to solve of how we get pharmaceutical care to patients in remote locations. And we've got to look, I think, at novel ways, test ways in which we can make that work for patients. Okay, some of these patients will come into Inverness and may go into a community pharmacy while they're there, but how do we get the routine care effectively managed with the input of a pharmacist is a challenge. And there's a numbers game, and going back to the convener's questions around workforce from the earlier discussion, of course, how do we manage within the managed service or from within a community pharmacy the capacity to provide that pharmaceutical care to the places that don't currently receive it. That's not an easy challenge, but I think we're on the way to testing some of the models that could help deliver it.
Professor Irvine?
Just to comment. One of the areas within Nest that I'm responsible for is what we brand as the Remote and Rural Health Education Alliance, which is very much aimed at supporting the education and training needed by all professional groups in remote and rural healthcare. And there's no doubt that there are huge challenges in delivering that agenda. I guess one of the most compelling messages that comes through consistently is the need to, quotes, grow your own, close quotes. In other words, if we get healthcare professionals into education and training who come from remote and rural backgrounds, they're very much more likely to want to go back and work in those remote and rural backgrounds. So we're doing a lot of work at the moment across all the professional disciplines at looking at how we can support and sustain that. And the other thing that I think is important to draw attention to is the use of technology to deliver education and training to remote and rural educations to support what are often very isolated practitioners, again, across all the professional disciplines.
Miles Mark.
Very glad of this question because remote and rural areas is obviously a big issue and something we're very interested in at the moment and really worried about as far as how to maintain really good services in remote and rural areas. We do need to remember that the NHS was invented in one of these areas in Ballachulish in 1912. It was proposed by Lachlan Grant and actually the Highlands and Islands was piloted as the Highlands and Islands Medical Service in our patch. And so the business of being able to use these opportunities, real crises, as a chance to pilot new ways of working should be something we should grab hold of. On the other hand, we're well aware that loss of dispensing has been the spark of causing quite a few crises in small rural practices, and we're very worried that will continue, and we're very grateful for the recent consultation on this to take this seriously, and I hope that some of the key areas that are going through problems will be helped by that process. I think it is always going to be difficult because there's these very areas with very few patient population and also very few clinicians. Actually, the proportion of clinicians to patients is quite high. It just happens to be a nurse and a GP. And we mustn't lose the expertise that particularly these dispensing GPs have got, providing fantastic community-based services to their patients, and in a lot of ways is the envious of some of us who work in less remote areas. So I think it's a really good point. I think it's something which, if this proposal of prescription for excellence is going to work, it's going to have to work in these areas too.
David Fliff.
Just to sort of build on that point, really, I think there will always be areas where we need dispensing practices, and those areas we need to recognise that they're not getting a full pharmaceutical care service as it stands, and then work out how we build on the services that are there to deliver that fuller pharmaceutical care service where possible. I think some of that is around how we support our dispensing doctor colleagues, around the dispensing elements in particular. Certainly speaking to local colleagues, that bit seems to sometimes get left out in terms of support from health boards, and we're certainly looking at that locally. But also how we plan those services, and thinking back to the pharmaceutical care service plan, how we make dispensing doctors part of that delivery of pharmaceutical care services, and recognise that they're part of that network as well as the pharmacies. So I think that would be important moving forward. And I think the consultation that we've just gone through will give us hopefully some tools that will give us a bit of stability, but also a clearer, I think, direction in how that pharmaceutical care service planning process will help support that.
You can also be remote in a peripheral housing scheme as well. And just in my area, the community pharmacist is maybe the last outpost there because the local shop shut down, it can't sustain, etc. We all know the scene. Now, if the future is more central dispensing, etc., how viable do these outposts remain? And this is an issue that we have already discussed with GPs in the deep end about access and equal access and time and supporting these communities. So there's a wee issue comes up out of the discussion this morning that gives me some concern about how we support those you know, the people in those communities, if a model of centralisation, dispensing, etc., you can't sustain a pharmacy in a poorer community, you know. So I don't know whether that is an issue or whether it's something that needs to be considered and all of this other stuff that needs to be considered. Lanigan, Professor Lanigan.
Totally agree with you. I think that Prescription for Excellence will build on that natural, unique selling point of community pharmacy, that it's accessible, it's available. It's the kind of place that's available in exactly the kind of situation you described. They're often the most accessible clinical practitioner in those areas, and I think that's really important. In Glasgow, you know, you would look at us as being an urban area. We've also got rural areas too, but for example, if you look at smoking cessation, the majority of smoking cessation quit attempts in NHS Greater Glasgow and Clyde are done through community pharmacies, very successfully. 30,000 patients last year, quit attempt, 30% success rate after 4 weeks. So that's pretty important to us in Glasgow that we maintain that, and that's done in the heart of these communities. So the public health, if you leave dispensing to the side, I think that will become less and less important to those pharmacies to maintain their income, and that their income will be derived from pharmaceutical care if we get this right. And dispensing will actually become a bit more of an overhead, and actually that might drive community pharmacies to find novel ways of providing dispensing services efficiently and cheaply. And I think there's some evidence of that. That's why you see some community pharmacies already investing in robotics, already investing in pharmacy technicians, already investing in perhaps coming together in hubs to dispense. So I think that community pharmacy has been quite creative in terms of how they manage the supply side. And I think if they derive their income from providing care, which is where we hope they will go, then I have no worries over the viability of these pharmacies. In fact, it might actually mean that there's even more demand to put care in these places. And then there also is the element of providing care in patients' own homes, patients who can't get out their homes. I think many community pharmacies now supply home delivery for prescriptions. Yes, that's a starting point, but also many of them will visit patients in their own homes to provide that pharmaceutical care. And I think that with the type of populations we are likely to see 2020, that will become the standard of pharmaceutical service.
Martin, you went in there. Yeah.
I too have a concern for pharmacies, not just in rural areas but also in urban areas. There might be outposts within urban areas and not necessarily on main streets, where if we are providing dispensing services from some form of factory, because the range of services that we provide are all cross-subsidised. There's hardly a single service that's provided from a community pharmacy that can actually financially stand on its own 2 feet, with the exception of the dispensing service. So there is a financial aspect to dispensing in a different way, because the dispensing service significantly subsidises all of the other NHS services that we provide. Parking that to one side though, the access that we have to patients, the opportunistic access that we have to patients as they present to pick up their medicines is fairly unique. And we do have the ability to access patients that otherwise often don't willingly go to other elements within the NHS. So I think we need to be really careful that whilst we are more clinically focused and expanding the range of services that we deliver, that we don't throw the baby out with the bathwater, and we do remember the unique benefit that providing a dispensing service actually brings with it.
David, please. Yep, I've got a couple of, it's on this issue, I think, and Bob wanted to make a supplementary as well. Richard, quick supplementary, Bob, a quick supplementary, and we'll bring the panel members back in.
It's been a very useful discussion, this, because I think the point that Martin Green was raising is pretty critical. That if we're actually funding the service through one element that's going to become less costly, in a sense, by roboticization and hubs and centralization, that is the dispensing, but we continue to fund on that we've got a problem with cross-subsidizing. And you know, it seems to me clear that, you know, if you take the urban area and then you take the very, very remote and rural, the very, very remote and rural, we need a new model for the continuing dispensing from a GP-based hub or a GP centre. It's the interface between those two where there's a real problem, and that's, we've got that here and now. In my area, we've had Lucas and Medvin where GP services have been significantly curtailed in branch surgeries as a result of losing dispensing. That's a reality. My constituents in Medvin now have a GMS service from 8 till 1 o'clock, where they had it previously the whole day. That's been cut in half as a result of losing dispensing. And Lucas is the same. So how we deal with that interface area where the increased viability of community pharmacy is leading for community pharmacists to establish themselves and provide a better service, a rounded service, a pharmacy service, which is welcome on the one hand, but if it's damaging the GMS services on the other hand, it's a real problem. So I just, you know, wonder whether anyone's got any comments about how we actually tackle this changing interface that we've got, which will change even further, and that's the point that Martin Green's making, as the mechanism for supply for the formal dispensing changes, that, you know, we're going to have a real problem with that area.
Bob, supplementary.
It looks very similar to what you comment. I was struck by Chris Flanagan's comment. It's about dispensing in part can be a red herring. That's clearly the business model. So if you're a dispensing pharmacist on a busy high street, you can make substantial amounts of money, and yes, you do all the other things, but that's the business model around that outlet. But Mr. Green also mentioned the idea of pharmacists becoming outposts, and I'm just wondering, I've got an area in Glasgow, Site Hill, where we've lost a dispensing pharmacist. Everyone still gets their blister packs through, but that's not the point. In an area that needs regenerated, the bricks and mortar of a community pharmacist, where the business model might not be there, but they are the only allied health professional in town for all the other forms of care that you would want the community to engage with on the ground via the bricks and mortar. So perhaps similar to Dr. Simpson, do we have to reconfigure the business model around community pharmacies to incentivise things other than dispensing, so that we actually can put community pharmacists in areas that are nowhere near a health centre hub, rather than round the corner from a health centre hub where they're actually in competition for dispensing profits? And I mean that with love. I'm trying to get where we get the community pharmacists where they are really needed.
David.
Lots of points now. The cross-subsidisation issue across pharmacy services, but also within dispensing doctors, needs to be at least brought out into the open and then considered. I think I would agree with Norman's point in terms of we are seeing supply efficiency driving robotics now. You know, regardless of where we go in terms of the contract payments in the future, we are seeing it now. And that will continue. In my view, it won't be government that drives the robotic revolution. It will be simply the supply efficiency. And the same will be true for dispensing doctors. Dispensing doctors will, I'm sure, access pharmaceuticals in that way at some point to be delivered back to the what you've called the dispensing doctor hub. I want to come back to the issue of the urban area where we see an outpost pharmacy. I think the issue for me there is that if you consider why, it's not the only reason why, but if you consider why we like GP practices as a source point to put services through, one of the key things, apart from all the wonderful personnel there, is that we can actually look at the people on that list and work out what their needs are, because they're a registered group of patients. As registration increases for community pharmacy, we will increasingly be able to do the same for a community pharmacy. And that will then create a value in those outposts that isn't necessarily seen there now, because we'll actually be able to say, this is what that community looks like in terms of its health. This is what that community looks like in terms of its needs. And we know that that community is using that particular pharmacy because they're registered for services there. And therefore, we will not just use that bricks and mortar for pharmacy. We will seek to also use it to put other services through as well. So you become an extension, if you like, of the primary care. I think network is a very good term rather than necessarily team, which I think has got a historical limit to it. And I think if we do that, then I think that all the health improvement things that we're talking about, smoking's a great example where community pharmacy is delivering pretty much, I say, across Scotland, the heat target for Scotland. If we use that as an example and we think along the lines of how we upskill, train, acknowledge some of the other staff that we're using in community pharmacy to deliver some of those health improvement messages, then I think we create a value around that I don't necessarily like the term outpost pharmacy, but if that's what we're using today, then it's a useful one. And I think that to me is how we'll create the value. And once you get the value, then you'll want to invest in it. The last thing I wanted to say was, it's a long time ago, but in 2003, when we had the original consultation on control of entry, we talked about not only identifying areas of unmet need for pharmaceutical services, but we also talked about over-provision, and that's gone off the agenda completely. But that does answer the question about where the market won't support a pharmacy at the moment and where perhaps we think we need one, and how we then use a system of either incentivising or subsidisation to actually get that service into a particular area. That's not on the agenda, I don't think. It doesn't come up in Prescription for Excellence in any way and was pretty much dead after the 2003 consultation. But it is something that may well be worth revisiting in terms of saying, well, as the model changes and that business model changes, if we do have consequences that aren't perhaps what we were aiming for, then we need to think about how we perhaps move from over-provision to under-provision.
Andrew?
Yeah, I was going to say, Prescription for Excellence for me contains a lot of good ideas, but what it doesn't do is it doesn't paint a picture of a vision of where we're going to. It talks about new and innovative models, but it tantalisingly doesn't say what they are. I think in terms of the outpost pharmacy in deprived areas, and we spoke about this earlier this month when we were talking about health inequalities, I think for me we need to build around the hub, the health hub in the community, and for me that the natural hub is the general practice, and I would want to see closer alignment between the community pharmacy and the general practice and all the other services, the district nurse, the CPN, because only by sharing the registration of the patients that you will avoid getting the muddle, which I think is a risk. You know, in my town we have 2 practices and 2 pharmacies, but in Glasgow you could have 50 practices and 50 pharmacies, and how can we possibly share the care of prescribing for something like hypertension if we have pharmacists prescribing, and I don't know the pharmacist. So I think we do need to think about separating off the dispensing element so that we can utilise the skills of the pharmacist and bring them into the primary care hub in these deprived areas.
Martin Green and then Professor Crommett.
On the issue of cross-subsidy of services, where it's a common theme both within dispensing GP practice and also within community pharmacy. However, they're not really directly comparable in the respect that I would go as far within community pharmacy to say there's more than just cross-subsidy, but to say nothing else would be financially viable without the dispensing service. So it fundamentally supports every other service. And what it in effect does is it delivers those services within the NHS very efficiently. Now, for example, the minor ailment service that I deliver through my pharmacies every single day of the week, if I was to pay for it from the money that's received for it, then I would only be able to cover the staff costs for 4 days. So providing the services that we do through a community pharmacy as a broad basket of services is a very efficient way of doing so.
Professor Crommett.
If I may, Convener, the first is an acknowledgement that, of course, there are very significant logistical constraints within the present system. The present system doesn't work, and I think it's a great pity that Dr. Hamish Wilson and Professor Nick Barber were unable to be here. I do hope, however, that all members of the Health and Sport Committee have read the Wilson and Barber review, because at the outset of that review is the evidence of base of why we're here. We are here because Scotland wastes £30 million a year on unnecessary use of medicines. We are here because up to 15% of patients are admitted to hospital as a result of iatrogenic disease. As if that's not enough, we give a further 10% of hospital inpatients an adverse drug reaction, which costs them ill health and costs society money. If we look at the more vulnerable patient groups, the elderly with complex conditions, those in care homes, the incidence of adverse drug reactions can go up as high as, of preventable adverse drug reactions, can go up as high as 30%. We have huge levels of non-adherence. So let's not talk about protecting a system which delivers effective pharmaceutical care. The present system does not deliver effective pharmaceutical care. And I think if you had Professor Barber and Dr. Hamish Wilson here, who spent a year looking at the evidence base across GP practices, across community pharmacies, looking at where pharmaceutical care was provided and looking at those patients who didn't receive it, we do actually have the testing of models on which prescription for excellence is built. It's not been dreamt up and it's not been explicit because there's a mix of models that have been shown to work through the efforts of implementing the right medicine, through the efforts of collaboration at Deep End and other effective collaborations between GPs and community pharmacists. We have evidence that works. What we need to do is to release pharmacists' professional time and enable them clinically through the efforts of NEST, through the efforts of health boards, so that they all come up to the clinical skills base that can provide effective pharmaceutical care. But it's no use defending a very time-consuming dispensing process as if that's what matters. What matters is releasing pharmacists' time from that process to provide more effective care so that we reduce the prevalence of unnecessary iatrogenic disease. It's not acceptable. Figures from across the water in the United States, some projections have demonstrated that the cost of iatrogenic disease exceeds the cost of conventional health care. But much of that is preventable. This is why Prescription for Excellence exists. It's about us collectively, all of the health and social care team, doing things more effectively to avoid harm in patients through the use of medicines. There's a great deal of scope for that. And that itself will save money at a time when the government doesn't have new money that we can invest in extending good models of care to those who don't currently receive it. So let's please remember why we're here, why Prescription for Excellence exists, and we all need to work very hard at overcoming the logistical barriers, some of which, of course, will concern particular stakeholders, but that's within the scope of the government modernising the GMS contract and the community pharmacy contract.
I'm wanting to get some other people in, Professor. The system's broken. Martin?
That's what I heard there too as well. And I do accept that clearly statistics would demonstrate that things need to be done better. But I would argue or contest that the system is not completely broken and we do not need to reinvent it. I would also contest that if you agreed with the direction of travel of the right medicine, and certainly within the community environment, the backbone, if you like, through which we would ideally be providing more clinical care is through the chronic medication service. And it is yet not fully implemented, so we're not really comparing a fully delivered model. Equally, we refer to patients of particularly high needs, such as those in care homes, and since the advent of the chronic medication service, which was how we would deliver ideally clinical care, patients in care homes have been excluded from the chronic medication service. So there have been many ways where we look at the current system and we are critical of it, but we have held it back.
David, did you want to?
Yeah, it was really to pick up on the two issues. One, I think, let's not delude ourselves that the dispensing payments that go to community pharmacy are for sourcing, labelling, and handing over the medicine. It's more than that, and I think, Martin, you would be the first to say it's more than that. So there is the advisory, the concordance discussion, compliance, etc. All of that support for the patient that goes with it. So let's when we're talking about efficiencies in the supply bit, we need to be clear about it's how that is sourced, produced, accuracy checked. That's the bit we're really talking about. I also wanted to come back on Andrew's point around the pharmacist prescribing, and really, Prescription for Excellence is a 10-year plan. It's not something that that gets turned on overnight, and so I think there is something about how we grow the existing systems that we've got at the moment, and I think it is about delivering that network. And I agree with the potential concerns around making sure that care is absolutely coordinated and is delivered within an agreed pathway to agreed guidelines, and that there is that sharing of information, because what we don't want is two arms, if you like, of care being delivered that aren't speaking, that aren't coordinated. And for myself, I see GPs as continuing to coordinate that care, but I also see a role for that independent prescribing within pharmacy, particularly around acute things. So, you know, we're using a lot of, we're at the moment treating uncomplicated urinary tract infections in Grampian through pharmacy. That would be something that would absolutely opens itself up to an independent community pharmacist prescribing role. So I think there's lots of good things being said, but I think we need to consider it is a 10-year plan. I don't think it's all or nothing. I think we will develop over time. And I think the point about it not being as prescriptive as the right medicine, I actually see the good in that, because I see it enables us to think about how locally we fit that into what is currently a changing model of primary care and a changing model of health delivery with social care, and allows us to make that fit locally. So I see some advantages there as well.
Anyone else want to take part? Professor Irvine?
Just briefly, I think Professor Cromarty rightly drew attention to the importance of education and training and underpinning a lot of this. And I think it's important for the committee to be aware that I think most of the building blocks that we need for what's in Prescription for Excellence are in place already, in terms of the undergraduate training, the pre-registration training, and the vocational training scheme that NEST runs, which I think probably, if I were to be self-critical, is currently very much secondary care focused. I think we need to do a piece of work looking at how we make that more primary care focused. But lastly, I think the importance of the commission stuff that we do around independent prescriber training. I think we have about 800 independent trained pharmacy prescribers now through that system, delivering significant numbers of prescriptions. So there's significant scope for delivery through that trained workforce, I would suggest.
I suppose that, you know, for the committee's point of view, that it's not just about the training of pharmacists or indeed GPs or whatever, or indeed the new health workforce. I mean, you know, in terms of delivering the 2020 vision, all of these services to be delivered in the community requires a new type of workforce. So, you know, how many GPs is against how many pharmacists, just on their own numbers? What areas will they be specialising in? Or what, is it more technicians that we need? Is it more you know, expert carers with some, you know? I'm not. Can you describe to us that there's some broader thinking taking place here, not just in the individual specialisms?
Absolutely, I think I can. Well, I think what your comment draws attention to is one of the comments in the report around workforce planning and some of the weaknesses that we have in that area as far as this professional group is concerned. I think it's relatively easier to do workforce planning around the managed service and a little harder to do it around the community service in pharmacy. And we certainly have significant intelligence within our organisation around, for example, dentistry and nursing that gives us some confidence that we could contribute more to the workforce planning around pharmacy. But I think your second point around the need to kind of completely change the model is very much illustrated at the moment in work that's going on within medicine as it happens through a process embarked upon about 2 years ago across the whole of the UK to look at the shape of postgraduate medical education and training, precisely to address the need for more care in the community, greater generalism and less specialism. So I think I can reassure you that very much there is work going on to address those priorities.
It might be something the committee takes an interest in a wider... Andrew and Martin's wanting them. Can't stop you now, which is good. That saves us.
I was just going to come in with some numbers there. We did the workforce survey last year and showed there were some 3,730 full-time equivalent GPs across Scotland, a small rise in the previous 3 years. In my 10-hour working day, I reckon that probably between half an hour and 1 hour of my time is taken up signing repeat prescriptions and sorting out specials and things like that. Much of that could be done possibly better by an attached pharmacist, and possibly up to an hour of my day could be done in terms of long-term condition management, adjusting doses of blood pressure treatment, things like that. So in a working day, up between 10 and 20% of my time could be freed up. Now that would be, do the maths, be somewhere between 300-400 GPs, whole-time equivalents, could be freed up across the Scotland to get involved in things maybe more particular to their skill set, like looking after frail elderly and keeping them out of accident and emergency.
Martin, you want back in again?
To pick up on the theme of workforce planning that you'd mentioned, and the development of the skills, if you like, within the broader pharmacy team, I think we need to make a decision quite early on whether or not we're going to make widespread use of the likes of automation, because the savings that are generated by automation is as a result of paying off your support staff. So, do we invest in our support staff, or do we look to automation? And for those that keep referring to the Dutch model, I recently visited Holland because it keeps getting mentioned, so I needed to find out what was going on. And about 1 in 5 Dutch pharmacies use automation. And has been, how Andrew mentioned earlier, actually, it does in fact completely transform the pharmacy, because you've got to redesign your pharmacy around a robot. But the efficiencies are generated as a result of paying off support staff, and the efficiencies that the companies who sell the machines will show you is all around paying off support staff and paying off full-time equivalents. Now, I'm not sure if that's what we want to do, but I think we need to make a decision on it, because we are currently training our support staff to take on more roles. Slightly unrelated perhaps, but around this concept of the general practice clinical pharmacist, I really need to know soon what that actually is. Who he is, what does it actually mean? I am imagining that they are prescribers through Prescription for Excellence. And if they are prescribers, then we've got some serious workforce planning issues around how we turn us all into prescribers. But I would just throw it out there that actually to deliver the kind of care that we can within community pharmacy, you don't really need to be a prescriber. Because most prescribing is done on an acute basis, and acutely unwell people are likely to see their GP. When you're managing long-term conditions and you want to make an adjustment to someone's medication, I think it's more than just courteous that you would lift the phone and speak with the GP. So your need to generate a prescription yourself is not huge. And I hear that from a number of prescribers. I'm not one, but those that run prescribing clinics, the occasions when they are called upon to actually write prescriptions are quite limited.
David, and then Professor Croft. David?
Yeah, sorry.
Yeah. You're waiting your light.
I mean, just to come back on that, I think let's go back to Andrew's point about how much time we can take out of the existing GP process in terms of the management of long-term stable patients. And if I look locally, we certainly have, I think the issue with CMS is that lots of practices are still on the uphill bit. They haven't reached that point where they see a significant reduction in that repeat pile. Now, I do have local GP practices who have reached that, and for them it's a game changer because they see the difference that makes in terms of serial dispensing. I think if we add to that the potentials that in the medium term that prescribing brings, what it means is that you have already agreed, and let's not get into the nuances of independent and supplementary, but essentially you have an agreed management plan for that long-term patient that you've agreed with the GP, and then adjustments within that can take place without having to do the technical bit of getting the GP to sign it off, because it's already been agreed that in response to this change in the patient, we will do this, and I think so. I think that's extremely valuable. I think I think a lot of pharmacists out there would say, do they need prescribing now in their current practice? They may well say in the community, no. I think if you go to hospital, completely different answer. They use it every hour of every day. But I think if you can explain to community pharmacists what that future looks like, then I think they absolutely see where the independent prescribing comes in. And I recognise the issue of coordination that we touched on earlier. So I think let's not underplay the potential value in unlocking capacity within GPs, but also unlocking capacity within pharmacists to deliver what they were trained for in the first place. They're not trained to just supply. Let's be clear about that. They're trained to deliver pharmaceutical care, and in the current format, we are not making the most use of that.
Professor.
I think it would be really useful, convener, to have a prescribing community pharmacist, a prescribing hospital pharmacist and a prescribing primary care pharmacist round the table to give us their evidence. They gave their evidence to Wilson and Barber. It's part of the report, and that's what PFE is built on. So there are distinct advantages in prescribing. I would contest Martin's statistic that most prescribing is acute, because we all know, of course, that 70 to 80% of all prescriptions are repeat prescriptions for long-term conditions. I would also maintain that it's very important that you have to hand, at the time of prescribing, the pharmaceutical care plan for the patient. Now, current prescribers may have that plan within their head when they're seeing a patient, but I know from speaking to my own GP that when he's rewriting my repeat prescriptions, he doesn't see all the therapy that I'm on when he's writing for one of the repeats at the time that he's writing it. So he's not aware of the other medication that I'm on while he's spending an hour writing a very large number of repeat prescriptions. In my book, and indeed in his, that's not effective therapeutic management. And that's not reviewing the patient at the time of the repeats because of the sheer workload that's involved that Andrew's referred to, an hour of his time writing repeat prescriptions. But who's reviewing that medication at the time of writing? Where's the input of the patient that that therapy is still going well? The opportunity we have by championing someone to take care of the pharmaceutical care of the patient is that they have that plan in front of them when they're writing that prescription. They're reviewing whether or not the patient's getting on well with that, whether it's the right dose, whether there are side effects. What we're talking about is more effective monitoring. And when you have that more effective monitoring, irrespective of whether it's a GP or a pharmacist that's prescribing it, but I would argue the pharmacist may be in a better position to take into account over-the-counter medicines, other effects, health promotion opportunities, and would have the time to do it in a dedicated clinic, then that's the opportunity that changes the nature of prescribing, I would suggest. And that's why it's very important and not incidental that the pharmacist prescribes.
Michael Pratt.
Right. I'm slightly concerned that what we're discussing is the needs of today. And we've heard about the capacity issues for today. I think we have to bear in mind that this is a 10-year plan. And if we look at prescribing volume growing 3% a year, year on year on year, and the demographic changes we know are coming, if they are not here already, the capacity needs of the primary care services in particular in 10 years' time are going to be vast. We need to do something different to help address those capacity needs of the future. So we need to use every set of skills that's available in the community. We have a valuable resource, we have a highly trained resource. We need to look at ways of using them. And if that requires community pharmacists to get involved in prescribing and use robotics more in dispensing, then we have to look at that. We have to look at different solutions for tomorrow. But our focus needs to be on tomorrow, not today.
Gil?
Just on that, and just listen to Mr. Green. Is the answer to this not that we need to reconfigure how we actually, can I use the word dispense, the rewards for working in the area? If the government and we're all agreed that we want to do more work, different work within pharmacies, but, and again I'm kind of speaking as a businessman rather than anything else, because that's really all I am. But if you're going to take the ability to maintain because the finances are not right, then surely we need to, through time, you're speaking about a 10-year programme, surely what we need to do is pay pharmacies different. If we want more people doing different things, and we think that's a good thing, then we need to change in a kind of tapered system where reliance is not on a particular aspect. It's a bit worrying if we knocked out dispensing out of pharmacy and it would knock everything out. That would worry me as a businessman. So we need to look at some logical way of changing and reconfiguring how people are paid in this regard.
Martin, you want to respond?
If you were to do that, you would need to do some very firm financial modelling around it. To go back to, like it or not, most community pharmacies are supported by their dispensing income or an income which is related to their former dispensing income. And if you wanted to drive behaviour differently by rewarding for other things, then you still need to bear in mind that the efficiencies of doing it all together, if you begin to break it up, you're going to need to meet the inherent costs of each individual service. So there is great efficiencies by pulling the service profile together and delivering it through community pharmacy. And the importance, I would stress, of the dispensing function that pharmacy provides isn't just around the cross-subsidy, it's about the access to patients. That is our unique access to patients.
We've got another 10 minutes. I mean, the objective for the committee this morning was to bring some of this discussion out for our own information in terms of the report and the imperatives that are driving it, issues that we have been involved in with the 2020 vision, the integration of health and social care. So, you know, we can't, I don't think, expect to have achieved much more than bring out the discussion that's already existing within your community and has been, you know, raging for some considerable time. We are dealing with something that's been described as a vision which is not set in stone, that needs to be discussed and delivered over 10 years. So I don't know, you know, I suppose that's the final 10 minutes. You know, what would you expect of the committee to be doing over its limited opportunities to work and understand this area, and indeed you know, priorities that we should maybe set ourselves over the next 2 years that we have got, about taking further consideration on this. Miles Mack.
Could I just say something briefly about the dangers of incentivisation, because this is relevant to medicines, and in general practice we've seen a large increase in polypharmacy. Some of that has been driven by financial incentives that have come our way through the Quality and Outcome Framework. And it's particularly galling that now actually in the Highlands we have been paid an enhanced service for polypharmacy to reduce that. So do be careful about what we incentivise. And I suppose the other question is be careful what other parts of the health service is incentivising, because it could have an effect on prescribing else in the wider context.
David?
It's not to tell the committee what to do over the next couple of years, but really just to re-emphasise something that was said earlier, and that is because we've had a lot of discussion about community pharmacy. And this isn't about community pharmacy, this is about pharmaceutical care in the community. And I think from the pharmacy perspective, I would ask the committee to remember that depending on the complexity of that care, because we'll be putting more care out of the hospital into community as well, and patients will expect more complex care in the community. So the pharmacy delivery of that, or the pharmacy elements of delivery of that, will involve the hospital pharmacist, what we call the practice attached, or the primary care pharmacist as we have now, and the community pharmacists in the future. And I think I would just make a plea that you remember that it is all of that resource that we're talking about, and not simply community pharmacy.
Dennis, you want to make a comment?
Just on that point, Convener, how do we ensure then that the patient remains the central focus in terms of taking this agenda forward? You know, because we are hearing about various business models and everything does need to stack up. I mean, it's obvious. But how do we ensure that the patient does remain the centre in taking this agenda forward?
So I think in the simplest answer to your question, we should be organising our services around the pathway of care that delivers care to a patient, and that's where your, if you like, your system level coordination comes in. So you're clear on who is doing what and at what point, and in response to what changes or what's placed in front of them in terms of the patient. I think from the patient absolutely has to be clear about who is assuring their care and coordinating their care. And I don't really, I see that as continuing to be and probably expanding the GP role. And that's a personal view, because I think as care gets more complex, that coordination role the importance of it will increase. I think the other thing is that the patient and that coordinator of care needs to be assured about all the other people who are delivering care, so that they're sure about not only that people are competent, but also that it's being delivered in the way that it's been agreed in a multidisciplinary way to meet the needs of that patient. And then lastly, I think this will develop incrementally at first. So I see Andrew's primary care pharmacist who he's working with attached to their practice. You know, that's a key start in this general practice pharmacist model. I see that extending and reaching out to community colleagues who are ready to move now, to engage them in an extension of that practice network. And that will move us eventually to the point where we have more community pharmacists developing that network model. But I do see it going back through and integrated with and collaborating with that coordinator of care and other providers of care. And because I think you're absolutely right in saying that the patient has to know who's delivering care, who is responsible, who's accountable, and that the care is going to be of high quality.
And how do you communicate that? How do you communicate that to the patient? And how do you try and ensure that the patient is confident that they're getting the best possible care from the best possible person? Okay,
so in terms of communicate, sorry, can I continue? So in terms of the communication, I think that part of that is registration. So if there's clear about registration for service and who is delivering that care, I'll be honest, I think part of it is working with colleagues to deliver under the confidence that's already in the system. So in that practice pharmacist model, where we've got a GP already working with that practice pharmacist, to me, the confidence in expanding that network comes in almost that assurance that it's linked with primary care as the patient understands it now, with the practice as it's understood now.
See, the Professor, yes, and then
if I may, to the point raised by Michael Pratt around capacity, but link it to the question that's just been asked. I think we need to focus our collective effort more upstream in the provision of health and social care if we're to be more effective in stemming the tide of long-term conditions and their debilitating complications. We just need to think of a couple of disease states to look at huge problems of capacity. We need to look, for example, at the increasing numbers of diabetic patients and all the complications that brings. And we've already got difficulty managing our renal patients, as well as our diabetic patients. If we look at the number of patients needing dialysis, that's on an ever-increasing graph with big capacity problems. So I think as the third largest healthcare profession, as the most accessible healthcare profession, it's incumbent on us all to enable pharmacists to make better use of their skills for the benefit of patient care. And the sooner that care is provided on a continuous basis to a patient through registration, I think the more effective we will be at managing it. But the other thing about the healthcare system is patients and society are too dependent on healthcare professionals. We need to enable patients to be partners in the management of their own care and to facilitate self-care, self-management, recognition that they've got a long-term condition, which they can actually do quite a lot about to improve their own quality of life in partnership with an evolving network of healthcare professionals who facilitate that. But they need to play a big role themselves in enabling that. And who's in charge of patient care? It should be the patient that's in charge of patient care, not the GP, not the pharmacist. It should be the patient. And we need to make them the centre, to come back to the point that's just been made, and enable that to happen. But we're far too downstream with a focus on secondary care and tertiary care. We need to get care out of hospitals, before hospitals, and keep patients out of hospitals, because as a society, we can't afford to keep on increasing the management of patients in hospitals.
Well, that's a good point. That radical idea that patients are in charge of their own care is a good point to maybe stop at this. But you anxious to come in, Martin?
Yes, if you don't mind. Sorry. But I've heard today from my NHS colleagues that it's quite good that Prescription for Excellence isn't very prescriptive, because it allows them flexibility in the way that they might choose to deliver particular services. Could I put in a plea that that flexibility and that uncertainty is not particularly useful for the commercial partners of the NHS, who will be required to invest within it and have done for the last umpteen years in terms of investing in their premises, investing in their staff, etc., etc. We need to see something a bit more concrete in terms of what's happening and where we're going. And finally, accepting that it is a 10-year plan, then it would be really good that, despite us accepting that it's going to be a bit of a journey, we do really need some really early, quick wins to keep engaged and keep focused on it. And there probably are some out there which are relatively easy to deliver and that we need to latch on to right away.
No response, you're quite happy? Professor?
Just very briefly, the patient's in charge of their own care, the businessman's in charge of his own business. PFE presents a golden opportunity to submit a business case to provide the care that's needed. Where are the business cases coming from? There's huge opportunity for community pharmacists to participate in this, just as there is for primary care and hospital pharmacists. No one's preventing that. Prescription for Excellence solicits that. We'd love to see business cases coming in about how that care is going to be provided, using the skills of community pharmacists.
You know, in terms of going forward and being inclusive, I raised the issue earlier about the steering committee and community pharmacists not on that steering committee. Is that helpful or not, given, you know, that they see, maybe incorrectly, too many of the downsides of this strategy, or at least some of the dangers? Is it
It's about
have they
more,
got a claim to be on that steering committee?
Well, so could hospital pharmacists and so could primary care pharmacists, or indeed academic pharmacists, who will also be involved in this. I think it's very important that the Royal Pharmaceutical Society sits round the board of that table, because we represent more than half of all pharmacists, and 2/3 of all pharmacists are working in the community. So community pharmacy is represented round the board table, as indeed our hospital. It didn't look as
if you were singing from the same song sheet here today, but you know.
Progress depends on robust debate. Status quo is no longer acceptable, so we've got to debate the issues.
Not me. But yes, you might imagine that as chairman of Community Pharmacy Scotland, and if we are to provide the vast majority of care within our communities, then we have made a direct request to be involved in that steering group, and we're not there. And you mentioned the word yourself, Mr. Convener, earlier, around hierarchy, and whether it's an intention or not, it is the perception that we leave with, that in terms of hierarchy, we are not at the steering group table.
Professor Lanigan, you have the last word.
Thank you. I really have to challenge that locally from NHS Greater Glasgow and Clyde. We recently responded to the first initiative from Prescription for Excellence by including the chair and vice chair of our local APCC in discussions about how best to take it forward. So in fact, I think if you asked our chemist contractors, our pharmacy contractors in Glasgow, they would have a different view. I think that builds on David's point that Prescription for Excellence supports local initiatives. We have many initiatives which have been designed by health board pharmacists, but delivered by community pharmacists. I can list you a length of these different initiatives, which we've designed payment structures to enable the community pharmacists to deliver in Glasgow. So I think that local bit within a framework, which is Prescription for Excellence, is the way ahead. I'd hate the committee to go away here thinking there was some battle between within the pharmacy profession. That's not my experience locally.
We're going to end it at that point. Can I thank you all very much for your precious time, the evidence and your participation in the discussion this morning. Thank you very much indeed. Thank you.
Okay. We suspend for a minute.
We only suspend for a minute, and I think the Minister, and then Agenda item number 3, which is, of course, subordinate legislation, the Scotland Act 1998, modification of Schedule 5, Order 2014 draft. As usual, with affirmative instruments, we'll have an evidence-taking session with the Minister and his officials on the instrument, and once we have had our questions answered, if there are any, we will have a formal debate on the motion. Can I now welcome the Minister and his officials, Michael Matheson, Minister of Public Health, Maurice Fraser, Bill Team Leader for Food Scotland Bill, and Lindsay Anderson, Solicitor, Scottish Government. Welcome to you all. I invite a brief statement from the Minister.
Thank you, Convener. Good afternoon. Since the Scotland Act 1998 was passed, the definition of food has changed at EU level, and certain animal feeds stuffs are no longer considered medicinal. Scottish ministers were given executive competence in line with this, which, amongst other things, allows secondary legislation to be made to give effect to EU law in this particular area. The legislative competence of the Scottish Parliament has not been updated, which means an Act of the Scottish Parliament is limited by comparison insofar as it can make provision in respect of food and animal feeding stuffs. The Section 30 order will ensure that the Scottish Parliament's competence to legislate in regard to food and animal feed stuffs is better aligned and with the executive competence of Scottish ministers, so that legislative competence rests on the EU definition of food and what now constitutes non-medicinal medical animal feeding stuffs. And I'm, of course, happy to answer any questions the committee may have.
Thank you, Minister. Are there any questions from committee members? There are no questions from committee members. We will move now to agenda item number 4, which of course is the formal debate on the affirmative SSI, on which we have just taken evidence. Apologies for that. So we, I suppose we need to go through the script. We remind members at this point that we don't put questions to the Minister during this session because it is a formal debate we're now in. Officials may not speak in the debate as they know. Can I invite the Minister to move the motion S4 M09803?
Moved.
Is there any member who wishes to participate in the debate? No. I will therefore put the question, and the question is that the committee recommends that the Scotland Act 1998 modification of Schedule 5, Order 2014 draft be approved. Do we have the committee's agreement? We agreed. We all agree. Thank you, Minister, for your brief visit. That concludes the committee meeting for today. Thank you all for your patience and participation.